Tuesday too, by the way. It's Test Tuesday. All right, C-spine. C-spine.
It's amazing.
C-spine.
You gotta fix it. Oh, time's on us.
Ready? All right, AP projection. Number 2, place the mid-sagittal plane of the patient's body perpendicular. Mid-sagittal plane is perpendicular to the midline. What's the mid-coronal? Parallel. They're always going to be opposite, guys. Okay, number 4, slightly lift the head back to prevent superimposition of the mandible over the C-spine. Vertebrae is 15 to 20 degrees cephalad. Why? Why do we angle?
Because the anterior's angle.
Because of the body and the lip in the body. So you either cephalad. If they're AP, remember? Okay. Central ray is to the thyroid cartilage, C4. Okay, quality check, C7 through C3 should be visualized. How come it doesn't say 1 and 2?
Because everything's.
Because the mandible is going to be in the way, as you can see there. Okay, also some places would like to see T1 and T2. They like to count down. Okay, intervertebral disc spaces should be open because we angled cephalad. It doesn't say it on here. Oh, it does say it. Okay. Rotation. Just like any AP spine, no matter if it's LT or C, what do you check for rotation? Spinous processes. They should be directly in the middle. We can look at the pedicles on the 2 sides to see if they're equidistant, but spinous processes should be directly down the middle. Okay, so what do you guys think about this one?
Could be a little darker.
Could be a little, it's this. This is new. It is better. I'm not going to complain. It's much better. I didn't know about it until just now. I didn't think they replaced it, but they did. I have to point over here. I didn't see it. All right, so we see the mandible. Here's the skull here, because these are, what are these? Those are the mastoid processes. So we know the skull is up in here, even though it's too bright, and I can't get it any darker. But we see the mandible here covering up. Actually, we only see, so here's the last rib is here, so that's T1, 7, 6, 5, 4. We don't even see 3 on this one. So this is not, what should they have, I did it. What should they have done? They should have lifted the chin up a little bit. Maybe they didn't angle either. They might not have angled to get up underneath there. So that's a little better. At least you can see 3. So there's T1 here, 7, 6, 5, 4. You guys can't see it, but I can see it on my fingers here. So here's 3 in here. Any questions? AP? Okay. Obliques. All right, starts out with RPO and LPO. Place the patient supine or upright facing the X-ray tube if you're doing posterior obliques. Then number 3, rotate the body 45 degrees for each projection. The midline should go down the sternocleidomastoid muscle. And again, just like the AP, try and protrude the chin, the patient's chin somewhat, just to get the mandible out of the way. Central ray, a 15 to 20 degree cephalic beam angle, centered at C4 when you do the posterior obliques, and 15 to 20 degree caudad when you do the anterior obliques. Not everybody angles on their obliques, but it's recommended to angle. Okay, the rule of thumb in all of these, don't worry about it, because nowadays we use one big size image receptor, but the rule of thumb is to put the top of the IR at the top of the ear and then just center to the center. You'll get it every time. You get the entire C-spine if you do it that way. That's the rule of thumb. 72 inches is recommended. Why?
Decreased magnification.
All right, you decrease the magnification from what?
OID.
OID, because there's so much OID when we do these obliques that if we increase the SID, it decreases the OID. Remember that? Okay, quality checks. For the RPO and LPO, you guys gotta know your TLC, we'll review when we go over the test review, but you have to know your different obliques and what they demonstrate. So it says right here, RPO and LPO will demonstrate the remote, which is the furthest from the image receptor, intervertebral foramen. RAO and LAO demonstrates the adjacent, the one closest to the IR, intervertebral foramen. Number 4, you should see all 7 cervical vertebrae on the obliques. There should be no reason not to see all 7. Okay, you guys can't see the marker, but there is a marker on there, but just by looking at it, what would you say this was? What oblique? This says RPO. You're right. See the way his face is? So he's like this. So this is RPO. Just look at the mandible. If in doubt, look at the mandible. See which way they're facing. Right, so that's an RPO. So, do you see the intervertebral foramen?
Oh.
Right there. So which intervertebral foramen is this? The left one. Okay, so the RPO would demonstrate the left intervertebral foramen. Camera malfunction. Of course, they didn't show me how to do this. I'm just trying to figure it out myself. And I can't get it brighter. Oh, no. Let's try another one. Anyway, so what oblique is that? What you can see of it?
LPO.
That's an LPO. See the back of the head and the mandible? So they're like this. So which intervertebral foramen is that?
Right.
Right. Remote. All right, laterals. All right, lateral projection. This is a neutral position, meaning that there's no trauma to the patient. So we just do a neutral position. So the patient is seated or standing left lateral. The mid-sagittal plane is parallel, so the mid-coronal is what? Perpendicular. Guys, you have to get this. Center of the coronal plane, which is goes along the sternal cleidomastoid muscle. Those of you that haven't had lab, it's that, well, you guys that had lab, where's that muscle? It's that muscle when you turn your head, that goes from your mastoid tip down your neck. It's the sternal cleidomastoid muscle. Again, like all the other ones, raise the head back to prevent mandible from superimposition. It recommends that you put, this is non-trauma, that you give the patient some weights just to pull the shoulders down. We did that in lab. And it does help. It does. We'll do it in lab. No more than 10 pounds simultaneously. Okay, center is the same for all these routine cervical oblique or cervical images, C4. Respiration, they tell you to suspend at full expiration because this also depresses the shoulders. If you breathe out, it supposedly depresses the shoulders. Okay, again, because of the OID, a 72-inch SID is recommended. Okay, quality checks. Number 1, all 7 cervical vertebrae should be seen, and at least, most places say at least the entire T1. This, your notes say at least 1/3 of T1. So if you can't get it, you've tried and you've given them weights, it tells you what to do. You need a swimmer. Okay? If you can't get T1, you need to do a swimmer. Okay. Number 4, you should see the apophyseal joints, the lower 5. Why does it just say lower 5? What's 1 and 2? 1 and 2 apophyseal joint.
Oh, 0 degree.
0 degrees. It sits at a different angle. We can see the apophyseal joint on the AP. So you won't see the C1, C2 apophyseal joint. Number 5 is important. I see it on a lot of registry stuff. This one shows a good lateral view of the odontoid. Did that just mess up? It was good when I Was it not good or was it also like that? Sorry, guys, I should have just put it on the blue box. It's not listening to me.
It worked when you brought your hand close to you.
Oh, I see.
I lied.
What I said. It was working. There it is. Very frustrating.
You can't do it from the actual mic.
No. This was laying on the desk, so I'm assuming it goes with that.
Mm-hmm.
But it's not good. I'm about to plug and bless you. I'm going to plug and switch to the new box. This is too frustrating for me. Until someone comes in here and fixes it or. It's not good.
Are the batteries good?
So cheap brand new batteries, I guess. I don't know. I'm gonna switch you guys. This is frustrating. We only have a couple left, and I just want you to be able to see. Alright, so. A lot of times it's easier to start at the top and work your way down as far as counting, because it's really easy to identify C1, because it's that ring-like looking one. So this is C1. C2, remember, how can we identify it really easy?
Spinous process.
That big fat spinous process. So you can see that here. So C1, 2, 3, 4, 5, 6, C7, T1. So this is a good one. We see all the way to T1, even a little bit of T2 here. What's this? These are the apophyseal joints. We see how the bodies kind of slant? So there's a little lip and they slant downward. You can see that here. What's this? Hyoid bone, very good. See the pharynx here? You see some cartilage in here. See how you can see the odontoid process? A nice lateral view of the odontoid process. So the odontoid process articulates with what? Posterior aspect of the anterior arch. Right there. What's this? Spinous process or posterior arch. So how would you critique that one?
It's missing T7.
Do you like the technique? Those are big, I can see. You're probably too far away. Technique is good. The shoulders are up too high. We only see 1, 2, 3, 4, 5, 6. We only even see the bottom of C7. So, and you can see C7s. What is that thing on C7? Good. The vertebral prominence, the whole thing is right here. We don't even see that. This one has the mandible pretty much out of the way. We could have pulled it out just a little bit more. I think flexion extension is next, right? Lateral for cervical. Number one, most important thing is do not remove any support apparatus. So if they have a collar on, if they're somehow or another supported, their head is supported, never take any of that stuff off. Number two, a crosstable projection must be completed before any other projection if it's a trauma patient. Okay. This will demonstrate in bold. Whenever I have something in bold, it's usually going to be on your test. This will demonstrate fracture or subluxation. Remember, subluxation is a what? It's a forward or anterior slippage. So we look at the anterior aspects of the body to see if they're all in one line. Number three, just FYI, I don't know if you guys do these crosstable for trauma anymore? I think I asked some of you that in lab. You've seen it once. Sometimes they do them, and sometimes they just take them straight to CT or MRI. So it all depends, but you should have it checked by a physician before you continue. Okay, as far as positioning is concerned, we went over the crosstable lateral with the Tspine. So make sure you know the important things in the Tspine, which we'll go over in review. So don't worry about this one because we already did it with the Tspine. Okay, optional views. Hyperflexion and hyperextension. Some places do these. We'll practice these in lab. Hyperflexion, just drop the chin as close to the chest as possible, and then you take the exposure. Hyperextension, you hyperextend the chin back to place the back of the skull as close to the back as possible. Okay, for quality checks, you need to know what each one demonstrates. Hyperflexion will demonstrate the spaces between the spinous process. If you think about it, if you flex your chin down, it opens up the back, the spinous processes. And it's the opposite for hyperextension. The spaces between the spinous processes are closed, and the spaces between the vertebral bodies will be open. Number 3, all 7 cervical vertebrae should be visible, and the reason why we do this is to see the range of motion of the patient. The very last part of that sentence. Bless you. All right, open mouth odontoid. All right, patient in supine position. You could do it upright if you want, doesn't really matter. A 30-inch SID, your notations and your Merrill says it, but a lot of places don't want you to do that anymore. But a 30-inch SID is often used for this projection. It just increases your field of view. What does that mean?
Magnifies it.
Good, okay. So since you're sick, don't get into me. Are you sick?
No, I'm not at all.
You're not? Oh, okay. When you decrease your SID, it works the opposite. When you increase your SID, it decreases magnification. When you increase your SID, it increases your magnification. So it's saying for you to go to 30 inches SID just to make the odontoid more magnified so you can see it a little bit better. So we used to do it a lot, but anyway, they're not crazy about it anymore. Number 3, the mid-sagittal plane of the head and body is perpendicular. This, for your cervical, it should say it for all of them. For your cervical, if they have dentures, ask them to take them out. You'll get the prettiest pictures. They come out much better without the teeth in there. Number 5, have the patient open their mouth as wide as possible, then adjust the head so that the line from the lower edge of the upper incisors, meaning teeth, to the tip of the mastoid process, they call that plane the maxillary occlusal plane, is perpendicular to the IR. Okay, so in other words, from the bottom of the upper teeth to the mastoid tip, it needs to be perpendicular. If you just have the patient either stand or when they lay down supine, it's going to be perfect. That line is going to be perpendicular. You don't have to do anything. It's pretty much perfect. If they're standing, just have them stand straight. Don't let them tilt their head back. Don't let them put their chin down. Just stand straight up and down. So that line is perpendicular. As soon as you get the line perpendicular, then tell them that no one wants to open their mouth. Just say, oh, keep it open as wide as you can, because they don't like to do it. They don't like to open their mouth.
Spell the name of that one.
Maxillary occlusal plane. It's on your little thing. M-A-X-I. All right. Okay, the central ray is perpendicular to the film at a level of C1, C2. It's just the midpoint of the open mouth. So right where the lips meet at the corner, that's where the central ray is going to go, right through that midpoint. It says you can tell them to say, I don't think I've seen anybody do that. Just depresses the tongue a little bit, don't worry about it. Okay, quality checks. You should see C1 and C2 and their articulations, meaning you should see the apophyseal joints in C1 and C2 along with the odontoid. So you should see everything. Number 2 and 3, you need to know if the base of the skull is superimposing the odontoid process. You lower the chin a little bit to get it out of the way. It's the opposite. If the teeth are over the odontoid process, raise the chin a little bit to get them up out of the way. All right, so let's look at these three. Let's start here. What do you think about this one?
It's really tiny.
It's pretty tiny.
I mean, for people to see.
Can you see this, the odontoid process? And like I said in lab, people call these spaces. It's really the apophyseal joint.
Was it the teeth are annoying you to pick up a little? Was it?
It's so close, just a teeny little bit up here. You see a tooth. Otherwise, this one's pretty good. I would not repeat this if I did. We can see the apophyseal joints. You want to see two. You can see the odontoid process. I don't think there's going to be a whole lot. Yeah, maybe they can lift the chin just a teeny little bit. Chad was saying that the teeth is in the way. What about this one?
Lower.
Why did you say lower the chin level?
Because the occipital bone kind of hits the top of it.
Good, okay. This is the occipital bone coming around here. So it's hitting the top. This one definitely needs to be repeated. So we're hitting the top of the odontoid process. They're gonna have to open their mouth wider because the teeth aren't too far away either. See how close that is? So either they're gonna have to open their mouth wider, or you're gonna have to do, what's the alternative? You have to do the Fuchs, okay? So, which we'll get to in a minute. Keep in mind, you always have to get these apophyseal joints on the open mouth odontoid because you will not see the apophyseal joints on the Fuchs. Okay, the Fuchs is only for the tip, the odontoid process tip. Okay, right, so you always need to see these apophyseal joints. Okay. What about this one? Perfect. Completely. Okay. The teeth are here. The mandible or the occipital bone comes around here. It's perfect. Nice wide apophyseal joint. All right, so like I said, if you try it a couple of times and you just can't get the odontoid tip, you switch over to the Fuchs. Okay, so there's two ways to do the Fuchs, or one way they call it the Fuchs, and it's the reverse waters, and the other way they call it the Judd, and it's the true waters. Don't ask me what those names are, I have no clue. I'm sure it's the people that invented the projection. All right, so for the Fuchs method, which is considered a reverse waters, you're probably saying, I always forget, you don't know what a waters is. We do a waters projection for sinus series and facial bone series. So that's what that means. Again, you should never, you never want to do anything like that if there's a suspected fracture. All right, so number one, the patient is in the supine position. That places the mid-sagittal plane, what? Perpendicular, mid-coronal, parallel. Y'all better not get that wrong on your test. Said it a million times. Okay, number three, extend the chin or the mentum until the tip of the chin and the tip of the mastoid process, they call it the mentomeatal line, are perpendicular to the IR. Center ray for this one is perpendicular to the IR at the level of C1, C2. So the beam is going to enter just slightly inferior to the mentum. Okay, for quality checks, like I said before, this one demonstrates only the odontoid process. Okay, and you will see the odontoid process within the foramen magnum. All right, the Judd method is exactly the same except it's done PA. Okay, so the Judd method is a true waters and it's done PA. Okay, so the patient is prone, not supine. All right, so here's the Fuchs. You can see that the chin, by the mandible, the chin is way up like this. You can see this is the foramen magnum here, and the odontoid process is right there. So the foramen magnum is circling around the odontoid process. You can see even the lateral masses of C1. All right, let's review. Vertebral column. Obviously know your 5 regions and how many numbers are in each one. Cervical has how many?
7.
Thoracic, lumbar, sacrum, 5 pews in the adult, and coccyx, 3 to 5, usually 4. Okay, in a child there's 32 to 34 vertebrae, and then the adult there's 36 or 26 because the sacrum and coccyx fuse in the adult. Okay, curves. What are your curves of the spine, the vertebral column? The cervical is convex. What's another name for convex? Lordotic. Don't worry about when it develops. The thoracic is concave anteriorly, which is what? Hyphotic. The lumbar is convex or lordotic, and the pelvic and or sacrum and coccyx as one is concave. Okay, terms related to the curves of the spine. Anytime that you see oses at the end, you've done your word roots, haven't you? What is it? You have not yet?
Yeah, I was on it today.
Okay, what's osis? The condition of having something. So lordosis is an abnormal or increased curvature, convex curvature. Kyphosis is abnormal or increased kyphotic curvature. Scoliosis is an abnormal lateral curvature. Clinical sign for scoliosis. Good. One hip you can, clinical just means you can see it. One hip is higher than the other. Okay, rotoscoliosis, that's the lateral curvature, and the vertebral column is rotated. What's the radiographic sign for that? An AP projection looks oblique. Okay, typical vertebrae. The typical vertebrae is composed of 2 parts, a body and an arch. Okay, the vertebral arch that and uniting with the body creates a hole or space called the vertebral foramen. Don't get it mixed up with intervertebral foramen. This is the vertebral foramen. When you stack up vertebral foramens, what do you create? Okay, the neural canal, spinal canal, vertebral canal, it's all the same thing. What does that house? Good, spinal cord and meninges. Okay, the body of the vertebrae are said to be cylindrical in shape. In between the bodies, from one body to the next, is an intervertebral space. Sitting in the intervertebral space is what? Intervertebral disc made of how many parts? 2 parts. What's the inner part called? Nucleus pulposus, the outer. Annulus fibrosus. What's an HNP? Herniated nucleus pulposus, so what happens?
Goes right through the
Good. The nucleus pulposus protrudes through the annulus fibrosus. Okay, the vertebral arch, this is make a little star, this is registry stuff. The vertebral arch is formed by two pedicles and two lamina. Okay, coming off the pedicles are the vertebral notches. So there's a superior vertebral notch and an inferior vertebral notch. When one superior notch comes together with an inferior notch, what does it create? Intervertebral foramen. Good. What goes through the intervertebral foramen? Good. Spinal nerves and blood vessels. Remember, the lamina are the broad, flat things that are directed posteriorly from the pedicles, and they unite and become what? Good. They unite and become the spinous process. Okay, the different processes. Transverse process, which way do they go? Good. They project laterally from the junction of the pedicles and the lamina. Don't worry about that part because it's different as we go up. Just that they project laterally. The spinous process, those always project posteriorly from the union of the two lamina. And remember, they mark the most posterior aspect of your body. Spina bifida, it's a defect where what? Good, the lamina fail to unite. And the two types of spina bifida, the one that's kind of hidden, you don't really know you have it, occulta. And what's the one where the spinal cord comes through? Good. So myelomeningocele is where the spinal cord herniates through the defect. Okay, articular processes, same thing as articular facets. So there's two superior and two inferior. Okay. One superior process connecting with the inferior process of another vertebrae creates what? Good, the zygoapophyseal joints or apophyseal joints. And we'll go over the different angles coming up. Okay, then we got into lumbar vertebrae. Okay, the bodies are the largest of all. The lamina are very thick, and on the lamina is something called the pars interarticularis. That's just that strong column of bone in the area of the lamina between the superior and inferior facets. Okay, spondylolisthesis is what? Forward slippage or subluxation of one vertebral body over another. Okay, the spinous processes of the lumbar. The tip of one spinous process corresponds to the inner space of the vertebral body below it. So if it's L1, it lies at L1, L2 inner space. It just kind of slants inferiorly, the spinous process. Intervertebral foramina in the lumbar region, they sit at a 90-degree angle to the median sagittal plane. So how would I open them up? Lateral. So I need to do a lateral lumbar to open up the intervertebral foramina. Apophyseal joints in the lumbar region, it ranges anywhere from 30 to 50. Specifically, upper is 52, midsection is 45, and lower is 32. How many degrees do we oblique the patient in the lumbar? 45. We do them at 45. We just pick the median range. Scotty dog, you need to know your parts of the Scotty dog. In the lumbar, if they're RPO and LPO, the Scotty dog points to the side down or side up?
down.
Good, points to the side down. So the parts of the Scotty dog, what's his nose? Transverse process. What's his eye? Pedicle. What's his neck? Pars interarticularis. What's his body?
Articular process.
It's the lamina. What's his ear? Superior articular process, and his foot? Good, inferior articular process. Okay, sacrum, it's composed, you already said it, composed of 5 fused vertebral segments in the adult. What's the top of, I just almost said it, what's the top of the sacrum called? Good, the top is called the base, and the most inferior part? Apex. Okay, the sacral promontory, that's the prominent ridge at the superior anterior edge that lies at the level of the first sacral body. They call that the sacral promontory. Okay, the sacral canal is located directly behind the bodies. And the sacral foramina are on the sides, and there's 8 total. There's 4 on each side of the sacrum. Okay, the ala or lateral mass of the sacrum is formed by the fusion of the transverse processes on each side of the body of the sacrum. So it's in utero, it's formed by the transverse processes. The registry questions have a lot of that on there. We already said the apex is the inferior part. And the sacral cornu, those are 2 small processes that project inferiorly from the apex of the sacrum. What do they join? They'll join the coccygeal cornu. Okay, just like the sacrum, the coccyx, the base is the upper part, and the apex is the lower part. And we did clinical notations for lumbar. Do you want to highlight those, or you already did it? You're good? Okay, T-spine. There's 12, like you said, 12 thoracic vertebrae. Their bodies increase in size from 1 to 12. And what's unique about them is that they have costal facets on them. Okay, the costal facets articulate with what? The head of the rib to form what? Good. The heads of the ribs articulating with the costal facet form the costovertebral joint. Transverse processes. Don't worry about with the exception of 11 and 12. The transverse processes also have a facet on them for articulation with what? Good. The transverse processes articulate with the tubercle of the rib to form the costotransverse articulation. The apophyseal joints in the T-spine, what angle do they sit at? Good, they sit at a 70-degree angle to the median sagittal plane. So if I started out lateral, what would I do? Go down 20 degrees. If you start out AP, go up 70 degrees. Intervertebral foramen, or foramina of the T-spine, what do they sit at? Good, they sit at a 90-degree angle to the median sagittal plane, and you would have to do what? Lateral to open them up. Okay, I want to make sure that you guys understand the anode heel effect. So let's just go over that. So that has to do with the APT spine, the anode heel effect. So where's the beam more intense? It's more intense at the cathode side of the tube. So where would I place the patient?
Towards the bottom, and then head towards the
The cathode would be towards the bottom of the T-spine because they're so big, and the anode would be towards the top. If you use a compensating filter, you put the thickest part where the thinnest part of the body would be. So you put the thickest part up here. Okay? So, because they're really thin, the T-spine are really thin up there. You guys didn't want to do notations. Okay, cervical. We're getting through this. All right, cervical vertebrae. The typical ones are numbers 3 through 6, meaning that they're most alike. So the atypical ones, starting with the atlas, that is it's also known as C1. It's ring-like. Some books say it doesn't have a spinous process at all. Some books say that it does. So it's ring-like, so we have an anterior arch. And like we already said before, the odontoid process articulates with the posterior aspect of the anterior arch. And it forms the atlanto. Thank you. I said it wrong, didn't I? No, I didn't. Atlanto-axial articulation. Okay, the posterior arch, that's where the spinal cord goes through. Okay, remember the transverse process of C1 are the longest of all of them. And also remember the lateral masses contain the superior and inferior articular processes. Okay, so the superior articular process of C1 articulates with the condyles of the occipital bone, and it's called the atlanto-occipital articulation. Okay, C2 is also atypical, known as the axis. It has the odontoid process, or dens is another name for it, coming off of it. It's a strong conical, shaped like a cone. It arises from the upper surface of the body, and again, it articulates with the posterior surface or aspect of the anterior arch. Okay, remember the superior articular process that articulates with the inferior process of C1 that forms the apophyseal joint. They sit at a different angle. We don't see them on, how do we normally see apophyseal joints in the C-spine? Normal apophyseal joints.
Oh.
Lateral, we see them on the lateral projection, but we don't see one in C2 because we see it on the AP. It sits at a different angle. Okay, so the other apophyseal joints sit at a 90-degree angle. The spinous process of C2 is the thickest one from top to bottom. And the last atypical vertebrae is C7. They call it the vertebral prominence. Some books just call it spinous process, the prominence. But anyway, it's because the spinous process is the longest of all of them, and you can palpate it on the back of your neck. Okay, typical cervical vertebrae are numbers 3 through 6. Okay, the bodies of the vertebrae are unique from all the other vertebral column because they're, number one, they're smaller. Number two, they slant downward and they have a little lip on them. Okay, remember the downward slant in that little lip creates a 15 to 20 degree angle inferiorly. So that's why we angle 15 to 20 degrees cephalad to open it up. Okay, remember all these cervical vertebrae have a transverse foramen on them, which is a little foramen on all their transverse processes for the transmission of what specifically? Good, the vertebral artery and vertebral vein goes through the transverse foramina. The spinous processes are unique, the ones that have a true spinous process, because they're bifid, meaning they have two little tips on them. There is an articular pillar in the cervical area, and that's the strong column of bone that sits between the superior and inferior processes. Okay, the apophyseal joints, they sit, numbers 2 through 7, sit at a 90-degree angle. Intervertebral foramen of the cervical area, they sit at a 45-degree angle. So how do we see those? Obliques. They also slant slightly inferior, so some people angle 15 degrees cephalad on the RPOs and LPOs. So how would you do it on the LAO and RAO? Caudad. Good. Okay, trauma patients, we talked about this, but make sure on your cross-table laterals, make sure you never touch any of the support devices. Recommended SID is 72 inches to decrease magnification. And Then there's some terms that you guys need to know. Jefferson fracture, there's a bunch of them that I gave you. Make sure you know your obliques and what they demonstrate. TLC, RARAAI. You guys good with that? Does everybody understand it? And you might not have memorized it yet, but you understand it. But I would, if you like that mnemonic, when you get your test on Tuesday, that would be the first thing I'd write down. Remember, the TLC, RARAAI is for what type of obliques? RPO and LPO. Does anybody not understand it? We good? All right, so the angles of the apophyseal joints. In the C-spine, they sit at a 90-degree angle, so we do a lateral. T-spine at 70, L-spine is 45, median range, intervertebral foramen. In the C-spine, they sit at 45, and T and L-spine, they sit at 90. I can tell you're not looking forward to this test. A lot of information. There she is. I almost forgot that I put diagrams on there. Diagrams. Let's see which ones are. Okay, put this one on the lumbar. There's one like looking down at it, and then there's a lateral. Superior aspect and lateral aspect. You want to hold that up and sample? Yeah. It's a big, kind of magnified. Huh? Yes, these are lumbar. Yeah. And it looks like everything's multiple choice. What you guys like? Yep. Yep. So there's 87 multiple choice, and then these diagrams. Okay, and here, this next one is the C-spine superior aspect and a lateral. C-spine. The first one was the L-spine. And the last one is the oblique Scotty dog looking lumbar. Do you guys have, do you want me to go over the numbers? Or the letters, sorry. The letters that correspond to these. You good? Did I fill in the letters on your diagrams? I did? Man, I'm getting too nice. No? You want to know just to make sure you got them correct? Alright, so let's go. I usually do that, and I completely forgot to do that. Do you want to just know the ones for the test?
Yes.
Okay. Alright, so that lumbar one. Vertebral foramen is letter F. The lumbar superior and lateral aspect. Everybody got it? Alright, so I'm just giving, evidently what I did was just put what it is. Let me give you the letters. Alright, so the vertebral foramen, this is kind of silly because you're not gonna memorize, anyway. On this thing, the vertebral foramen is gonna be letter F. The superior articular process is A. Shanna took a picture of it, so it wouldn't be fair. The spinous process is B. The lamina is gonna be C. I just kind of went in a circle. The transverse process is D. Pedicle is E. I didn't do the body. H is the superior vertebral notch. I got this wrong. Hang on. E is the pedicle, yes. H. Oh, hello. You guys are not gonna know this. Never mind. Giving you, because part of it's the bottom, the way I did it. This is gonna confuse you. Cause I didn't give you this exact looking one. And I did some on the top and some on the bottom. So don't write down the letters cause it'll just confuse the heck out of you. You want the letters? I'll give you the letters. Okay, so I said E was the pedicle, H, and I'm looking, it's the lateral one, is the superior vertebral notch, and G is the inferior vertebral notch. Inferior vertebral notch. Okay, I'll give you the letters. All right, the cervical one. Starting at the top one, the superior aspect, E is the lamina, G is the superior articular process, B is the transverse process, F is the transverse foramen, C is the pedicle, A is the vertebral foramen, D going to the lateral one is the spinous process, and H is the inferior articular process. Okay, on the Scotty dog. The cervical one more time. Yeah. E is the lamina. G is the superior articular process. B is the transverse process. F is the transverse foramen. C is the pedicle. A is vertebral foramen. D is the spinous process, and H is the inferior articular process. Pardon me?
So there's only one from the bottom?
Two, D and H. Okay, all right. The Scotty dog guy. Scotty dog guy. Lumbar Scotty dog. All right. A is going to be the pedicle. And don't write I. I'm doing the anatomy. A is the pedicle. D is the lamina. B is the pars interarticularis. C is the transverse process. F is the superior articular process, and E is the inferior articular process. You good? All right, we'll do lab at 10.
I was gonna finish it with that.